Hey, it's Dr. Bill with just the tip of urology school. Today, we're going to discuss briefly penile lesions. Commonly, we'll see condylomata in our practice, and depending on the anxiety level of the patient, reassurance is uh, very often utilized. And occasionally, unless you're bulletproof certain on the diagnosis, you want to take a biopsy to make sure it's condylomata. And subtyping is important because there are HPV subtypes that are associated with carcinoma in situ in the female partner. Also look for pre-malignant diseases, Bohinoid uh, papillosis, Bowen's disease, often HPV related. And the pre-malignant status, just a biopsy and some local treatments and observation are certainly appropriate. We use a lot of topical creams like 5FU, and there's some guidelines for you on that. The big issue is penile cancer. We don't see it that often, but when we do, it can be obviously devastating to the patient. Probably about 95% of the cancers that we see on the penis are related to squamous cell carcinoma. Risk factors will include patients who are uncircumcised, those with chronic inflammation, human papilloma virus, tobacco use, and the use of certain ultraviolet light treatments that are utilized for other skin conditions. It's important to have that area shielded. Um, on physical examination, once you have made that diagnosis and it's done with a biopsy, then we look at a good physical exam of the inguinal um, lymph nodes. Sometimes, if we are concerned about some enlargement of inguinal lymph nodes, we'll give a short course of antibiotics to see if that reduces. Other than that, then we're left with lymph node dissection along with a surgical intervention for the penile lesion once a biopsy is obtained. And that may include um, partial excision of the glands, partial penectomy, and even total penectomy, along with a lymph node dissection and consideration for bilateral lymph node dissections, TNM staging, like most other cancers in urology, looking for the size of the tumor, the local involvement or invasion of penile structures, any nodal involvement, and um, evaluation for metastatic disease. Primary treatment revolves around surgical removal of the lesion with consideration of chemotherapy and radiation. We will have patients who absolutely refuse an excision or partial penectomy for obvious reasons, and we can sometimes use a combination of radiation and chemotherapy. Probably the biggest take home is that there are a number of lesions that are either benign or pre-malignant. So having a good understanding of what they look like, being comfortable in a biopsy, um, uh, using a biopsy information to solidify your diagnosis, and really feeling comfortable with physical exams regarding inguinal lymphadenopathy. Obviously, we're going to be using radiographs in the form of CT, MRI, and even PET scans for staging as well. A lot of information on a rare disease. Certainly rely on your guidelines in the AUA. There are a number of handbooks for the nurse practitioner, PA, and medical students that will outline nicely various bullet points. Don't be afraid of the assessment. Read a little bit about it. You won't see a lot, but you'll mostly see benign disease. Have a comfort level, again, when you need to take the next step. And as always, talk to your supervising urologist if things don't seem clear. Dr. Bill, just the tip of urology school with penile lesions.